Good morning. Thank you all so very much for coming. So happy to have so many people in the room. And we had 20 submissions of videos from the audience, many of which we have used today. My name is Elise Day. I'm at Mass General Hospital in Boston. This is Nicolas Veit-Rubin, and he's at Medical University at Vienna in the Department of Obstetrics and Gynecology. And in the back of the room, coming up shortly, is Philippe Zimmern, and he is in urology at UT Southwestern. Can everybody hear me? Okay. So this workshop is under the guise of looking at, by the way, I have no disclosures, nor does Dr. Zimmern, beyond a book of the same title. This workshop is really in response to all of the complications that we've had with mesh. There was a generation of trainees who really trained during the mesh era, and the goal of this workshop is to really reestablish and explore further native tissue options. My section of the talk will be a brief description of the anatomy, which most people in this room do understand, and then we will go to stress incontinence, anterior repair, vault suspensions, and posterior repair. We will have audience videos embedded within our presentations, and most of this talk will be videos. There's not a lot of data presented. At the end of each section, we will have 5 minutes for audience comments and questions, and if your video is being presented, please stand at the microphone while it's being presented. So here we have the anterior vaginal wall, and we are looking at the periurethral support as continuation of the support of the anterior vaginal wall. Really, it is the condensation of the endopelvic fascia laterally. And that is best seen in this MRI image where you can see the urethra and the condensation of the endopelvic fascia laterally to the arcus tendineus fascia pelvis. The midurethral slings pass either through the retropubic area or through the transobturator area, and later there will be a presentation of a transobturator midurethral sling. The birch is based on attachment of the vagina lateral to the urethra and the bladder to Cooper's ligament, and the sutures are left off of tension on purpose. It's important when dissecting in this area to be aware of the anatomy. This is a really nice article exploring the anatomy of the space of Retzius, and the corona mortis is a vessel to be avoided in this surgery and should be looked for prior to dissecting and placing sutures. Cystocele, there are central cystoceles, and more often we have loss of lateral support. An important concept is also a transverse defect near the pericervical ring, and that will be explored in one of the videos today. We all know Delancey's long-standing description of level 1, 2, and 3 support. Again, here we see the arcus tendineus fascia pelvis. Here's a surgical photo with sutures directed toward the arcus tendineus fascia pelvis. The anterior vaginal wall suspension, which Dr. Zimmern will present, recapitulates lateral support by helical sutures, lifting the entire anterior vaginal wall upward. Here's a simplified schematic of the lateral support, the anterior arcus tendineus fascia pelvis. And pictured here, when we're looking at vault support, is the sacrospinous ligament. The cephalad support also is in the form of the uterosacral ligaments, which are often used surgically for support. The cardinal ligaments are not as frequently used, but there are growing concepts on the cardinal ligaments. Here one can see the iliococcygeus muscle, which is used for vault suspension as well as rectocele repair. This is a nice MRI article on the cardinal ligaments and the uterosacral ligaments. The uterosacral ligaments are like Chinese fingers, those toys that you can get at birthday parties. If you stick your finger into the side of it, there's really no strength. but when you pull it lengthwise, there's strength. So sometimes the uterosacral ligaments can disappear. For example, in the case of rectopexy, if you are thinking of doing a vault suspension with your colorectal surgeon, sometimes they sort of dig through the uterosacral ligament and it's no longer there. It's really just a condensation of the fascial layer. This is a picture of the uterosacral ligaments in a well-supported vagina. This is a patient without prolapse. It's important to understand that underneath the uterosacral ligaments are the pelvic splanchnic nerves eliciting from the sacral nerve roots. So stitches that are too deep can injure these. Here's a laparoscopic view toward the pelvis. Here are the uterosacral ligaments in a patient who does have prolapse. Notice how different they look. We all look for the ureter, but not many of us know to look for the hypogastric nerve. Nucelio Lemos, who's an ICS member, runs a beautiful course on the neuroanatomy of the pelvis, and he has people dissect out this nerve. It's quite a long, strong nerve bilaterally. We're not talking about anything to do with mesh today, but I'm showing this image to show the hypogastric nerve, which can be noted and avoided during sacrocolpopexy. Now, rectocele, there are 4 defects: a weak prerectal fascia, which is really just the circular muscular layers of the vagina; a widened levator hiatus, which can be reconstructed; an open perineal membrane, which can be addressed with paranorrhaphy; and then descent of the levator plate, which one can see best in this image. Descent of the levator plate really requires a vault suspension for support. Here we have also a site-specific defect, which can be repaired with sutures.